So thank you very much for the opportunity to talk to you today in these difficult times. So I do quite often talk about prostate cancer, but again, this is quite special because this is COVID time, so we have to adapt, and I've tried to adapt this speech to the current times, and I will try to tell you how really I think that COVID is impacting the way we're treating patients. So this is about not only sequencing, but most importantly, choosing systemic treatments for the patients with advanced disease in these current COVID times. My disclosures. So first of all, I would like to remind you that actually TREM2 is a key molecule with which the virus, the COVID-19 virus, can actually bind to the body. As you can see here, ACE2 is also a very important receptor where to attach, but TREM2 is also a very important protein. Without it, the virus has much more difficulty to bind to the body. So potentially it's a target for treatment to prevent COVID infections. Why am I speaking about TREM2? Well, I'm speaking about this protein because actually in the prostate cancer field, we know quite well TREM2 because 10 years ago, fusion genes between TREM2 and a series of oncogenes from the ERG families of oncogene was discovered in men with prostate cancer. It's actually a quite frequent finding. Approximately half of all the patients with prostate cancer do have these fusion genes between TREM2 and ERG. And due to that, the ERG oncoprotein is being made in excess. Actually, very importantly, TREM2 is a downstream gene to the androgen receptor axis, which means that theoretically, every time we're using hormonal therapy, we should be able to impact on TREM2 activity. So, of course, it's tempting to think regarding the COVID-19 pandemic that hormonal therapy, and especially androgen deprivation therapy, may actually protect from the infection. And actually, it seems to be the case. We just saw a couple of days ago, actually, the first data supporting that, published in Annals of Oncology. And this data comes from Italy, where, as you all know, probably there are many cases in northern Italy of COVID-19. And actually, in this region, they looked at all their patients with COVID-19 disease. They find that some patients actually had prostate cancer, and actually some had prostate cancer with ADT, as you can see here. And actually, the number of cases of COVID-19 in men with prostate cancer and hormonal therapy was very low, as you can see here on the slide, with a relative risk of just 4 for the androgen deprivation therapy to protect from the virus, which is big. And the same findings were also suggested regarding the incidence of severe COVID-19 disease. Again, the relative risk was about 4, favoring men on castration. So actually, when your patients in your practice are asking you the question, Doc, am I at risk for suffering from COVID-19? Well, actually, you can tell them that not only very likely they have prostate cancer, their risk is probably not much more than the patients, but actually it might be even less if they are receiving androgen deprivation therapy. Now, let's come back to systemic treatment for advanced prostate cancer. So this figure, which is now busy, and it's a good news that it's busy now, is showing the natural history of a disease from either localized disease to death from prostate cancer or from de novo metastatic disease to death when things don't turn well. And you will see in blue the drugs that were available 10 years ago. So in summary, just androgen deprivation therapy, docetaxel, and zoledronic acid. And then you will see in red the drugs that were approved in the last decade, first in very advanced stages with abiraterone and enzalutamide, cabazitaxel and radium-223, denosumab replacing plus or minus zoledronic acid, and then all these drugs going up front more and more. And I will come back to that. In the last years, we had strong data supporting that we should use these drugs earlier. So now that we have all this good news, and of course assuming that they are available, because I know very well that they are not necessarily available in all countries, depending on your health system and whether patients need to pay out of pocket or whether they have private or public health insurances. Of course, it makes a big difference. But let's assume that these drugs are available. The question now is how best should we use them for the best to our patients? And actually, I see four potential strategies to use these drugs. One very important strategy, obviously, is using them earlier in the course of a disease. So let me try to first expand on that, and then I will come to the second, the third, and the fourth strategy that we may look forward. So first, earlier treatment using these drugs. What do we have? Well, of course, 5 years ago, we saw for the first time data in men with de novo metastatic prostate cancer, suggesting that if you're using chemotherapy immediately together with castration, in the long term, patients will do better as compared to ADT first and then docetaxel when patients develop castration-resistant disease. Actually, 4 trials were reported, and they all point out to the same direction, as you can see. So the overall analysis of these 4 trials supported 23% reduction in the risk of death when docetaxel is being used upfront together with castration. Fine, very nice. Having said that, there were actually 2 trials, let's say clearly positive, with actually one outlier, which was the American Chartered trial, supporting a 40% reduction in the risk of death. But actually there were also 2 trials that were much less convincing in terms of overall survival. Our own Frangitic 15 trial, as you can see, the confidence interval clearly crosses the 1 bar. And that was also true for the second docetaxel arm of the Stampede consortium, also with confidence interval crossing the 1 bar. So not totally sure that everything was pointing to the same direction. But actually, in the last 2 years, we've seen updated analysis of these trials, and actually it seems that these 2 here were a bit over-optimistic, unfortunately. For example, if you focus on Chartered, initially 5 years ago it supported a 40% reduction in the risk of death, but with longer follow-up, 2 years ago, an updated analysis supported only a 28% reduction in the risk of death, and as you can see, the curves tend to cross with time after 4 to 5 years between ADT alone and ADT plus docetaxel. So it was actually much less strong as compared to what initially reported. And actually, unfortunately, the same data was reported 6 months ago with a Stampede docetaxel comparison, again showing that the amount of a benefit in overall survival was smaller as compared to what people thought it was initially, just 19% reduction in the risk of death. So yes, docetaxel reduces the risk of death when used upfront, together with castration in de novo metastatic disease, but actually the benefit is less than 20%, and I think it's important to remember this. It's better than nothing, but still patients are dying. Now, 2 years later, back in 2017, we saw the first data from the abiraterone phase 3 trials. So 2 trials were actually reported at the same time, Latitude here to the left-hand side and Stampede here to the right-hand side. And as you will see, the shape of the curves is almost exactly the same. The benefit in overall survival appears starting 6 months after randomization, and the longer the follow-up, the greater the benefit in overall survival when this was reported first back in 2017. So you might say that the same phenomenon that we saw with docetaxel might also be seen with abiraterone, with a lower efficacy in the longer term, but actually it doesn't seem to be the case, which is really good news. This is, for example, the updated analysis for overall survival of Latitude that we reported last year. And as you can see, with longer follow-up, the curves still diverge very nicely. The medians have been reached. 3 years in the control arm with ADT alone versus more than 53 months in the experimental arm with abiraterone, so this is much better. And actually the hazard ratio didn't really change as compared to the original analysis, with a 34% reduction in the risk of death, which is quite important, of course. And on top of that, I'm often being told by my colleagues, well, if my patient is symptomatic, I may actually use chemotherapy rather than abiraterone. But actually, when you look at the data, this is absolutely not supported by the evidence. And actually, when you're looking, for example, at time to pain progression in the Latitude phase 3 trial, you will see this big difference. Median is about 17 months in the control arm with castration alone, somewhere here, versus 47 months, somewhere there, for the abiraterone arm. So again, big difference in terms of time to pain. And actually, those data were not really clear with chemotherapy as reported in the phase 3 trials. Also, if you're looking at quality of life, I think this is, to be honest, one of the most impressive difference in quality of life probably ever reported in oncology with a drug. Look at this data. This is really big data for quality of life, clearly favoring the abiraterone arm as compared to the placebo arm. And this is change from baseline. You see quite rapid deterioration in the control arm starting 6 to 12 months after randomization, while quality of life is actually improved and then maintained with abiraterone for almost 3 years or so. So I think this is very important to remember, because again, this is not something we see very often in oncology, whatever the drugs, unfortunately, regarding quality of life. Actually, in Latitude, all secondary efficacy endpoints on top of progression-free survival and overall survival were significantly improved, and very significantly improved, as you can see here, just looking at the p-values. So whatever the way we looked at the data, abiraterone was better than the control arm. Now, you might say, well, this is very nice. We have abiraterone, which clearly works. We have docetaxel, which was shown to work also, maybe a bit less, maybe less convincing, but basically these two drugs don't really work the same. So maybe we should use them both, especially in men with a high cancer burden at presentation, because maybe the combo of the two drugs together with castration may achieve an even better job. And this is exactly the question we're asking in the PEACE-1 academic phase 3 trial. And actually, this is looking at two questions: whether abiraterone adds something on top of the standard of care of ADT plus docetaxel, and also whether local radiation therapy actually helps in this context. The good news is that we were able to complete the accrual in this phase 3 trial with 1,200 patients being randomized, as you can see here. We completed the accrual by Christmas time in late 2018, so approximately a year and a half ago. These patients are on follow-up, so hopefully we will see the first data maybe next year. Now, some of you might say, well, again, this is very nice. Using abiraterone obviously is something that works, but actually I may be concerned by exposing my patients to long-term steroids. This is something we pay a lot of attention in the development of abiraterone. This is, for example, a pool analysis of the COO301 and COO302 phase 3 trials that actually look at these two trials in terms of grade 3/4 steroid-related side effect as compared to the control arm. And you see that actually the incidence is very low, just between 1 and 2% grade 3 or 4, and it doesn't really increase over time. Same, of course, if you're looking at weight, gain weight over time, you might say, well, my patient is on prednisone for 5 years, maybe he's going to be super fat. Actually, it's not really the case. This is the increase and here the decrease in numbers of kilos. So this is just 1 kilo. And you will see that those are the two abiraterone prednisone arms. You know, as a median, patient just tend to take no more than half a kilo or so of abiraterone and prednisone in this context. So that's not really meaningful to me. This is very reassuring because, of course, I was very anxious about seeing lots of patients with diabetes or with obesity in the long term. It really doesn't seem to be the case just because basically prednisone is replacing what we're removing with abiraterone. Now you might say, well, very nice, we can use safely corticosteroids in normal times, but those are not normal times. Again, COVID-19 is out there. So can we safely use corticosteroids? Some 2 to 3 months ago, we were very cautious about that and very expecting data and fearing that patients with on corticosteroids might actually develop very severe COVID-19 disease. With now 2 to 3 months experience with the pandemics, it doesn't seem to be really the case. Of course, we still need to be cautious, but truly with the current experience, we haven't seen really much more patients on corticosteroids developing severe COVID-19 disease. And actually in some patients, we've demonstrated COVID-19 ongoing disease. The use of steroids could be done for various reasons with no additional toxicities. So again, we need to be cautious, but the first data that we've seen seem to be reassuring. Now, on top of abiraterone, in the last year, we've seen a series of new phase 3 trials testing new drugs, such as enzalutamide and apalutamide, in this context of de novo metastatic prostate cancer. For the sake of time, I won't detail everything. This is, for example, just the Enzamet overall survival analysis showing that similar to abiraterone, enzalutamide also improves overall survival when compared to standard of care, and the same data was reported with apalutamide in the Titan trial. The Arches trial is actually too preliminary to tell. Only PFS data were really reported. The OS is clearly immature. But those drugs are very similar at the end of the day in terms of efficacy, and so this is not really a surprise, knowing that abiraterone works and enzalutamide and apalutamide probably had to work. But it's good to have, though. The question for us, now that we, of course, if you do have access to those next generation hormonal agents, is whether we should use, say, abiraterone or enzalutamide on top of ADT, or should we use docetaxel? And to try to address this question using the data that we have on hand at the moment, I use in this presentation a color code where you will see the hormonal therapies in blue and the chemotherapy in red, just to try to figure out what we have. So let's review what we have. First, we have some direct comparisons between the two kind of treatments, and you will see here that ADT plus abiraterone wins in terms of progression-free survival as compared to ADT plus docetaxel in the Stampede comparison. And again, this is direct comparison of men directly randomized to receive either abiraterone or docetaxel. So I think this is very important to remember. Unfortunately, when data were reported, the follow-up was just 2 years or so. So, of course, almost all these men were alive. So it was too early to tell regarding overall survival. We will need a longer follow-up before we can truly analyze whether there is a difference in overall survival between these two arms. Now, you can also do indirect comparisons looking at pain or quality of life using, for example, latitude data and charted data, because actually they use the same questionnaires. So actually you can align patients in the control arm to make sure that they are similar between the two trials, so that you can actually compare using a Bayesian technique the two experimental arms, abiraterone here in blue and docetaxel here in red. And you will see that whatever the criteria you're looking at, quality of life or pain, actually abiraterone wins. This is here quality of life, which was clearly improving while on abiraterone immediately after randomization, while with docetaxel we see a quality of life deterioration initially during the first month, and then after an improvement, but actually even with this improvement, the quality of life is never as good as what abiraterone achieves. Same data actually is seen with pain. With pain you see actually a stabilization with chemotherapy versus the control arm, and then a deterioration due to cancer progression, while with abiraterone not only you see an improvement, but this improvement is actually much more long-lasting. So again, very important data supporting abiraterone use and not chemotherapy in this situation. Now, and at the end of the day, the most important is, of course, overall survival. So here in this table, I ranked the hazard ratio from best to worst regarding these phase 3 trials. We now have 9 phase 3 trials testing these agents versus castration alone. And you will see here that it seems that the blue team, so that of the hormonal therapies, actually seems to win, with approximately a 35% reduction in the risk of death. Actually, this is very stable across trials. This is abiraterone, this is abiraterone, this is apalutamide, this is enzalutamide. So very, very similar data, approximately 35% reduction in the risk of death. And then, and actually much lower, is the hazard ratio for overall survival with the docetaxel trials, more in the 20% reduction in the risk of death, as already suggested by the meta-analysis. So even if this is not direct comparison, again, the trend clearly supports potentially a greater effect from next generation hormonal therapy in terms of overall survival, as we saw in terms of progression-free survival, and also in terms of pain and quality of life. And actually, this difference in outcomes favoring the hormonal agents is not explained by the use of treatment beyond progression in the control arm from these various phase 3 trials. Because as you can see, actually the incidence is very similar when looking at chemotherapy phase 3 trials. This is JETUD 15, 66%, and hormonal phase 3 trials, this is Latitude, 57%, Enzamet, 48%, Charted, 48%, etc., etc. You don't really see a trend favoring or disfavoring the hormonal agents or the docetaxel agent. Patients tend to receive salvage therapies quite the same across the board. Now, to finalize the situation of de novo metastatic disease, very important is also to remember that overall survival is actually improved when using radiation therapy directed to the primary in men with oligometastatic disease from de novo metastatic prostate cancer. This was shown by the STAMPEDE investigators. As you can see, there is here better overall survival with radiation therapy as compared to ADT alone, while for patients with a large burden of disease, you don't really see a difference. And actually, it's the only real situation where counting the number of metastases, looking at the volume, if you will, or burden of the disease, is helpful to decide whether a patient should receive A or B as a treatment. Here, this is telling us that if a patient has, say, less than 3 bone metastases, radiation therapy to the primary should be used, while when in patients with a larger burden of disease, it's not really going to help patients. So take-home message for de novo metastatic disease is that the main current standard of care, in my mind, should be ADT combined with abiraterone. Now, ADT plus Taxol is an option, but to me this is only by default. If abiraterone is not available or too expensive for the patients, something like that, but truly not as a primary option. Having said that, some patients are too frail or too old to get these agents, so in these men, ADT alone should remain the standard of care, just because some patients cannot receive chemotherapy or cannot receive a steroid. Very important again, radiation therapy should be advised directed to the primary cancer in men with oligometastatic disease. Of course, when apalutamide and enzalutamide are approved and reimbursed, they might replace abiraterone. Also, of course, looking at the cost of these different agents. Finally, in the coming 1 or 2 years, we will know from the ARASENS, PEACE-1, and ENZAMET phase 3 trial whether 3 drugs are better than 2. So stay tuned regarding this question. Very important regarding cost is looking at the access to generic abiraterone. And this is an informal survey that I did last year, asking over the phone or by email friends and colleagues over the world to try to figure out where abiraterone was available or not as a generic. And as you can see, it's coming in many, many countries. And of course, it's now much more than that at the moment, which is very important to all the patients because cheaper price means that more patients can benefit. Now, the second situation regarding the use of earlier use of a disease is obviously looking at non-metastatic disease. And in the last 2 years, we've seen data from 3 phase 3 randomized trials assessing next-generation AR-axis targeted agents in men with non-metastatic castration-resistant prostate cancer. So this is, for example, the Spartan trial with apalutamide, the Prosper trial looking at enzalutamide, and now the Aramis trial looking at darolutamide. In all these 3 trials, as you can see here on the slide, we saw a strong benefit favoring the experimental arm, here darolutamide, for the primary endpoint of metastasis-free survival. For example, here the placebo was associated with a year and a half time before the patients developed metastasis or died from the disease or other causes, while it was postponed to 40 months in the darolutamide arm. So obviously a very big difference between the 2 arms. Now, on top of that, I can say publicly now that this data is now supported by overall survival improvement. The data will be presented in a week's time at ASCO, and the abstracts are now out, so you can have a look if you wish at the ASCO website to read them. And I can tell you that significant overall survival improvement is now demonstrated, supporting these agents' use in this setting, thus confirming this original data of metastasis-free survival. Now, regarding the safety of these 3 agents, Of course, we don't have direct comparisons, but we at least can look at the data for safety versus their own placebo. So for example, this is Spartan here, apalutamide and placebo here to the left-hand side of this table. You will see that, for example, for fatigue, you see approximately a 10% difference disfavoring the apalutamide arm. Now looking at enzalutamide, it's even a greater difference, 43% fatigue with enzalutamide versus 14% with placebo. For darolutamide, it's a different situation, 12% versus 9%, almost no difference for fatigue. And actually, this is probably due to the fact that darolutamide doesn't penetrate the blood-brain barrier and this is different to the two other agents. So this actually might explain why the two other agents are associated with fatigue, not darolutamide. Similar data were seen with other CNS-related side effects, such as mental impairment disorders, but also falls and fractures. For example, with enzalutamide, 11% falls versus 4% in the control arm. With darolutamide, it's actually numerically less than the control arm, 4% versus 5%. And same for bone fractures. This was increased with enzalutamide or apalutamide, not with darolutamide. Hypertension is seen in excess with enzalutamide, as major adverse cardiovascular events are. Rash is also seen with apalutamide, hypothyroidism as well. So you see, even if these three drugs work, darolutamide seems to be the less toxic as far as we can tell it from non-direct comparisons, and of course with all the caution that is required in the setting. Okay, I took my time regarding this first strategy about using the drugs earlier, because I think it's fair to say that in the last 5 years, this has been a win in our strategy. This is more and more what we are doing. So let me try to explore now the second strategy, which is that of using this drug sequentially, one after the other one, depending on what the patients had received first. So first, a big question to us, and this has also implication in terms of cost, is should we keep using the old hormonal manipulations before moving to abiraterone or enzalutamide, for example? Actually, we have two randomized trials looking at this question. The Terrain and Strive randomized trials compared in early metastatic CRPC old generation treatment with bicalutamide or next generation treatment with enzalutamide using a progression-free survival primary endpoint. And actually what was reported in these two trials was that clearly next generation trial is better. Bicalutamide was associated with progression or death within 6 months as a median, while enzalutamide postponed that to more than 15 months. Very clear difference, no discussion, and actually the same data was reported in Strive. For the sake of time, I won't show you the data. So we have probably all reason now to use abiraterone or enzalutamide earlier. The only caveat to that is the cost, to be honest. But otherwise, using the old generation drugs do not make a lot of sense. Now, that is fair. We are using abiraterone or enzalutamide, but these drugs are not curative. So what should we do next when they don't work anymore? This was actually looked at first in retrospective experience, and actually they all pointed to the same direction, which was not a good news actually, and that's a high cross resistance between the two agents. You will see here, for example, that using abiraterone post enzalutamide, that just doesn't work, with response observed in just 5% of men. And actually, if you're using the reversed sequence, it's not much better, just approximately 20% response rate with enzalutamide post abiraterone, and it typically doesn't last long. So this is not really good, to be honest. Now, of course, people were still interested using these two drugs sequentially, And the Canadians randomized the two sequences, so ABI followed by ENZA or ENZA followed by ABI. And what they showed was that if you truly want to use these two drugs as a sequence, and I just show you that this is not necessarily a very good idea doing, but I know that some patients want to do that also. But if you're doing that, I think that the abiraterone followed by enzalutamide sequence seems to be better, as reported by the Canadians. The difference was significant, favoring ABI followed by ENZA versus ENZA followed by ABI. And actually, the similar trend was reported in overall survival, favoring abiraterone first. Having said that, actually, if you truly want a drug that works after ABI or ENZA, you should go to taxanes. And this was also reported as a retrospective experience in the past. This is, for example, the analysis, retrospective analysis of the COO302 phase 3 trial, so probably the largest experience ever reported. And you will see that many more men benefit from the Taxol after abiraterone failure as compared to men with absolute taxane refractory disease. So very important to remember. And actually similar data were reported with cabazitaxel. Again, retrospective experience, you will see that many more men receiving cabazitaxel after abiraterone and actually the Taxol failure benefited from cabazitaxel as opposed to men who are refractory to this agent. But of course, some people were still skeptical and were wondering whether we should keep using the two hormonal agents sequentially instead of using a taxane. So the CARD phase 3 trial has tried to address this question. And actually in CARD, patients with metastatic castration-resistant prostate cancer who had received already abiraterone or enzalutamide and Taxol were randomized to receive either the second taxane, so cabazitaxel, or the second AR axis targeted agent, abiraterone or enzalutamide, depending on what they had received at the first place. And the primary endpoint was radiographic progression-free survival. As you can see, CARD was a positive phase 3 trial. Clearly, cabazitaxel did a much better job as compared to the second AR-axis targeted agent, abiraterone or enzalutamide, with a 46% reduction in the risk of radiographic progression-free survival. So very clear difference. Don't pay too much attention as to whether the patient has received abiraterone or enzalutamide first. Whatever that drug, cabazitaxel will win against the second AR-axis targeted agent, here enzalutamide, there abiraterone. So cabazitaxel is better in this setting. And actually at the end of the day, even overall survival was significantly improved favoring the cabazitaxel arm. So I think this is very important to remember. It's not so often that in oncology, a fourth-line treatment is actually associated with overall survival improvement. Here, this is the case with cabazitaxel. Now, you might say, that's fine, but how should we use chemotherapy in the current times with COVID? And actually, this is a very important question, I think, to all of us. Very recently, we reviewed all our experience here at Gustave Roussy, at my center, regarding patients with cancer and COVID positive patients, about 12% of the total patients that we screened for COVID-19, so total of 137 patients. And we looked at who is developing severe COVID disease. And actually what we could show was that performance status and the type of cancer, hematological cancers versus solid tumors, are the two main risk factors in univariate analysis to predict COVID-19 deterioration. So patients requiring high volume of oxygen or needing a transfer to the intensive care unit. So two parameters, fine. But what about chemotherapy? Actually, chemotherapy is also associated in univariate analysis with a risk of worsening from COVID-19. So you will see here, for example, the curve of patients who did not receive chemotherapy in the last 3 months, whatever they had metastatic disease or not, versus patients who received chemotherapy in the last 3 months. So I think this is important to remember. If you're giving chemotherapy, your COVID-19 patients will be at a higher risk to deteriorate. Now it's also important to look at other systemic treatments. We looked, for example, at targeted agents such as TKIs, and we could not find any difference versus other cancer patients. So this is reassuring for those of you, for example, who do kidney cancer. This is very reassuring to us. Same thing was found regarding immunotherapy. This was obviously a big question. Of course, we don't have so many patients, just 12 patients receiving immunotherapy with COVID-19 cancer patients. But as you can see here, there's no evidence that these patients have worsening of their COVID-19 disease. So in multivariate analysis, actually only performance status was truly associated with worse COVID-19 outcomes. Chemo was borderline significant. As you can see here, maybe we don't have enough patients, but I think it's fair to recognize that there is probably an increased risk of worsening from COVID-19 disease when we're using chemo, but it's not very big. So if you have a good reason to use chemotherapy, the benefit for your patient is probably higher than the risk that he will develop worsening of his COVID if ever he develops COVID. Now, the third strategy to use all these drugs for castration-resistant disease is combination treatment. Here I will be brief because, unfortunately, in the past, all of the combos of new drugs with docetaxel were actually associated with failures, which was not good news. Let me drop directly to what's more probably important to us. And this is looking at the combo of bone targeting agents with other castration-resistant prostate cancer drugs. Because this is probably something we haven't done enough in the past, and probably this is something we should do. Why is that? In the past, the ERA-223 tested the use of radium-223 on top of abiraterone, and actually not only the trial was not positive, but also the combo of abiraterone together with radium was shown to be worse as compared to abiraterone alone. And investigators were able to suggest that the use of bone targeting agents, denosumab or zonulic acid, might actually improve that. There is actually a second phase 3 trial currently ongoing. This is a PEACE-3 trial, and it's randomizing enzalutamide alone together with radium. Based on the ERA-223 experience, the PEACE-3 investigators were able to amend their protocol so that the use of bone targeting agents, so denosumab mostly, was mandatory after the amendment. So actually, a year ago at ASCO, Bertrand Tombal reported the data regarding the risk of fractures before and after the amendment. And what he was able to show was that fractures were seen with a very high incidence in men receiving enzalutamide plus radium. As you can see here, this is almost a 50% incidence by 2 years after the start of treatment. So this is huge. Half men develop a fracture by 2 years' time. And even with enzalutamide alone, the green curve, you see approximately a 20 to 30% incidence by 2 years' time. This is big. Now look here at the red and black curves, which are that of enzalutamide with or without radium-223, but in the context of denosumab or zoledronic acid. This clearly prevents the onset of fractures dramatically. And I think this is very important to remember for the practice when we're using abiraterone or enzalutamide in metastatic CRPC. We should really say it's probably the good time to start denosumab or zoledronic acid. And if we believe it's not the good time right now, we should, at the latest, start these bone targeting agents when patients develop resistance to abiraterone or enzalutamide. I think this is a very practical take-home message for you guys. And please remember that it's not only fracture, it can be also spinal cord compression, as you can see here on this bone scan. The incidence was about 8 to 10% in the placebo control arms from phase 3 trials in patients not receiving bone targeting agents. And zoledronic acid is able to reduce the incidence down to 4%, and denosumab probably decreased that even stronger, down to 2.7%. Now, and last, I will focus the last part of this presentation to personalized treatments and to novel agents that might arrive to the market in the coming years. And to do that, I will just show you this data on genomics from patients failing abiraterone or enzalutamide used for CRPC. As you will see, the number one way for the cancer to develop is actually to reactivate the AR pathway, which is very important to remember. It means that if we are able to invent a new abiraterone, a super abiraterone, or super enzalutamide, then we will probably win again. Now, on top of that, the PI3 kinase in some men seems to be activated by PTEN loss, and then this can be potentially a target for treatments. And the third big thing could be also DNA repair defects, which is now more and more appealing as a potential target for treatment. So let me review what we have. For example, you know that regarding the hormones, testosterone and DHT are the two main hormones that can bind to the androgen receptor. We all know that for a long time. Fine. Castration can take care of that. But a number of other androgens can also bind to the androgen receptor, mostly those made by the adrenals. You might say, this is fine. We actually have abiraterone to actually prevent the making of these androgens. That is true, but unfortunately, in cancer cells, even on abiraterone at progression, some androgens can be detected, again, at the cell level. So one way or the other, the cells are able to find some androgens or to make them when they progress on abiraterone. So actually, in these men, we might need to just shut down completely the hormone making. And this is also because androgen receptor mutation can make the androgen receptor stimulated by other non-androgen hormones, such as progesterone, for example, or glucocorticoids. So we might need to completely cut the making of hormones downstream to the cholesterol, and there are actually drugs doing that, such as ODM-208 or ODM-209, and those drugs are currently under phase 1 assessment. Of course, you need to supplement your patient on mineral steroids and on glucose steroids, otherwise they might die from adrenal insufficiency, but of course this is something quite easy doing. We know how to do it to treat Addison disease for decades. So stay tuned, this is potentially something important doing. The second pathway to target, again, is that of the PI3 kinase AKT pathway. In a minority of men, approximately a third, PTEN is lost in the cancer, so this pathway is activated together with AR pathway. So the lab data support the use of dual targeting of the AR pathway and the PI3 kinase AKT pathway. So is this true also in patients? A randomized phase 2 trial supported that indeed it might will be the case. This is, for example, what was seen in patients with P10 loss when combining abiraterone together with an AKT inhibitor. You see better outcomes versus abiraterone alone, and this is randomized data, which actually was not really seen in patients with P10 normal cancers. And actually the same data was observed whatever the dose of a drug, 400 milligrams or 200 milligrams. You see a benefit here in P10 loss, no benefit there when P10 is normal. So if this data is true, this could be an example of personalized and precision medicine to decide which treatment should be used. The phase 3 trial has not completed its accrual. We are expecting its first data, hopefully before the end of the year. The third pathway to target is that of DNA repair defect. As you probably all know now, approximately 10% of men with advanced prostate cancer have germline mutation, mostly concerning BRCA2. And on top of that, an additional 10% of men have similar mutation in their cancer, so no germline, but only somatic mutations. So 10 plus 10 equal approximately 20% of the total, so it's a big minority, to be honest. The phase 2 trials reported efficacy with PARP inhibitors, and this is why phase 3 trials have been designed, and we now have data out in the New England Journal regarding the first phase 3 data, which was called PROFOUND, and this is looking at olaparib versus abiraterone or enzalutamide in men failing a first AR-axis targeted agent, so either abiraterone or enzalutamide, and for most of patients failing also a taxane. And you will see that olaparib wins as a basically third-line treatment versus the second use of a switch, if you will, to abi or enza when a patient has already received one of these two drugs. Very clearly for a primary endpoint of progression-free survival, and there is also suggestion that even OS might be improved. There is also pain progression, and as you can see, olaparib does a much better job as compared to the control arm, and please remember that these cancers are aggressive, very often associated with pain. Now, very important in the future will be to better dissect whether all these genes, these DDR genes, are good targets for treatments. I think it's fair to say that BRCA2 is a good target, very clear difference between olaparib and control arm. CDK12, probably yes. ATM, probably not. But all the other genes were too rare in the phase 3 trial that we can tell whether there is or not a benefit for these patients. We will need more data. Now, as you all know, immunotherapy is being used in oncology quite a lot, and this is really trying to find a way for these two cells, T lymphocytes and antigen-presenting cells, to better discuss, to avoid the breaks. We are using these agents in many cancers. In prostate cancer so far, phase 3 trials have been negative, but mostly because of a design and because only a minority of men progress, because actually at the individual level, these drugs work. This is, for example, one of my patients who received ipilimumab almost 10 years ago now, after he had progressed on hormonal agents and docetaxel, and actually he benefited tremendously. Total normalization of his bone scan, total disappearance of bone pain. He could stop the opioids. PSA went down from 120 to 0, and it's been continuously 0 until now, which is almost 10 years after the start of treatment. So things we never see with other non-immunotherapy treatments. So those drugs work. Unfortunately, in this phase 3 trial, for example, the trial was analyzed just 2 months too early before we could see the excess in long-term survivors in the trial to get a positive phase 3 trial. But remember that those trials were done before the melanoma experience, So we didn't know at that time that we would win with immunotherapy with a long-term difference. Sorry. So this is for ipilimumab, but actually the same data was also recently reported for PD-1 inhibitors. Those are the 5 first patients that were ever reported back 4 years ago, showing clear efficacy in a minority of men. We now need to identify who these patients are. Obviously, MSI high is a very important biomarker to look at if you want to know who might benefit from immunotherapy, and this seems to be true for prostate cancer. More recently, actually a year ago, data supporting that inactivation of CDK12, which is found in about 7% of cases in prostate cancer, might be a good way to identify patients most likely to benefit from immunotherapy, and trials are ongoing. Also, very recently, tumor mutation burden was suggested to be a good way to identify who are the patients who benefit from CTLA-4 and PD-1 targeting with prostate cancer. Again, validation is needed. Finally, the last, very sexy potential target that is coming is PSMA. PSMA, as you know, is a transmembrane protein that is very often expressed in prostate cancer. A ligand combined radioisotope can be used to better identify patients in terms of imaging using a PET PSMA. As you can see here, this is probably the best imaging that we have in prostate cancer. But on top of that, we might use a radioisotope such as lutetium to target prostate cancer cells expressing PSMA. And actually, as you can see here, the first phase 2 data reported quite dramatic efficacy even in patients failing next-generation hormonal agents and taxane. So we're now waiting for the first phase 3 trial, which hopefully will be reported before the end of the year. This is a large phase 3 trial with a potential for approval of a drug. It's called VISION, and it's comparing PSMA lutetion versus best treatment in patients failing abiraterone or enzalutamide and a taxane. So stay tuned. Hopefully we'll have data before the end of the year. And actually in a week from now at ASCO, you'll see data from a randomized phase 2 trial looking at PSMA lutetion versus cabazitaxel in the same space. So as you can see, we now have more and more biomarker driven treatments in metastatic CRPC. For example, DDR positive cancers can help identify who are the patients that can benefit from PARP inhibitors and likely also from carboplatin for those who cannot afford paying for a PARP inhibitor. MSI high may identify patients that can benefit from PD-1 or PD-L1 inhibitors. And actually many others are probably coming very soon, such as PTEN loss for AKT inhibitors, AR mutations and ligand inhibitors, CDK12 and immunotherapy, and PSMA PET for PSMA targeting. So, and all this will likely be available with data within 6 or 12 months. So in conclusion, the early treatment of advanced prostate cancer clearly seems to be better than deferred treatment. We now have evidence and strong evidence, including overall survival improvement, that the use of drugs such as abiraterone in the M1 castration-sensitive setting or other AR axis-targeted agents in the M0 CRPC setting are associated with improved outcomes. Also, the sequential treatment still is all routine management for patients with CRPC, but we now have better guidance regarding which drug should be used. For example, docetaxel after abiraterone or enzalutamide, cabazitaxel later on, and PARP inhibitors in men who have a DDR defect. Combination remains experimental at this stage, with one exception, which is that of patients needing a bone targeting agent these agents can be safely used and should be actually used together with AR axis targeted agent or taxanes. Very important is to remember the high cross resistance between abiraterone and enzalutamide, and of course, this is probably true also with apalutamide and darolutamide. The good news being that taxanes remains active after abiraterone or enzalutamide failure, and starting probably a year ago now, biomarker-driven medicine is arriving in advanced prostate cancer. And with us, I thank you very much for your kind attention, and I'm very happy to take any question if you have some. Thank you.